I don't have the answer. But I All right, has the bewitching hour arrived? I believe so. Do we have a quorum? Well, let's see, we've got Commissioner Bertland, 1, 2, 3, 4. That's a quorum. Yeah. All right, well then I will call the meeting to order. Shall we have the pledge of allegiance?
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Okay. Roll call.
All right. Glenn Bailey,
Here.
Dr. Johnson,
Here.
Commissioner Cowles,
Here.
Commissioner Bertling,
Here.
Dr. Nolan,
Here.
Peggy Cavala, Chairman Fletcher.
Here. Okay. Public comment. We have a young lady in the background over there. Are you from the public?
No, I'm actually the medical reserve corps coordinator here.
Oh,
This trip. I'm just a trip.
oh, well, welcome.
Thank you.
So not seeing any public, let's move on to item 5, consent agenda. Aaron?
In the consent agenda this month, we have standard information related to the last meeting. Also, the division reports. There is one longstanding contract that was signed, and that's related to the Fit and Ball program. We've been involved in that program for a number of years. We have participation in all 5 counties. It's a program specific for older adults, 60 and older. It's intended to improve their mobility and strength and minimize falls. We have about 90 leaders, and if we count participation, not individuals, we do have thousands of participants each year in this program. So it's about 85,000 is what the contract amount is for. Funds most of it.
Okay. Are there any calls to extract one of the consent agenda items for further discussion? Going twice? Going 3 times? Then I will entertain a motion to approve the consent agenda.
Mr. Chairman, I make a motion to approve the consent agenda as here presented.
Okay, any seconds? Okay. Any objections to the consent agenda? Hearing none, let the minutes record that it was passed unanimously. All right, so now for nutritional services. Ms. Young, you're up. Thank you for your patience, by the way.
Okay, well, thank you actually for letting me come back and speak this month, because I wanted to make sure that you got the full presentation of nutrition services. And actually, just to introduce myself, my name is Kim Young. I oversee our home visiting programs, which is Parents and Teachers and Nurse Family Partnership, as well as nutrition services. And in nutrition services, we have WIC, which is Women, Infants, and Children, lactation services, and our diabetes programs. But today I get the pleasure of focusing on our WIC and our lactation services. I will briefly touch on lactation services. So what is WIC? WIC stands for Women, Infants, and Children. WIC is actually now in its 50th year. So it started as a pilot program in 1974, and it was in response to malnutrition and undergrowth in pregnant women, infants, and children. And so healthcare providers and public health officials were actually seeing some issues with anemia. They were seeing high rates of anemia and undergrowth. And so WIC was actually developed based off other models that occurred to address these issues through a supplemental nutrition program. And in this program, it's designed to help women, infants, and children by providing the healthy food, nutrition, and breastfeeding support. Waiting for you to advance, but it's not it. And I went back. There we go. Okay, so who is eligible for WIC? So you must be categorically eligible. It's women that are pregnant, breastfeeding up to 12 months past delivery, or up to 6 months postpartum. So if they are not breastfeeding, then they are eligible for 6 months. And then, of course, infants and children up until their 5th birthday. So when they turn 5, they no longer qualify for services. They also must live in Idaho. And then they also must meet the income guidelines, which is 185% of the federal poverty level. They do automatically qualify if they are already on Medicaid or SNAP or food stamps, because the income level would already qualify them. However, we do have a lot of working families that may make more than what Medicaid would allow them to make, so they would still qualify for our program. All right, so how does WIC work? So we do provide healthy foods, and each WIC participant, or if there's multiple participants in a family, they must engage in at least 4 appointments per year. So we start off with a certification, And then in mid-year, they have a health screen, which is very similar to the certification without going through all of the qualifications. Also, between the certification and the health screens, they have follow-up appointments. So they come in with nutrition education and receive that. If they're high risk, they do see a dietitian. If they are lower risk, we have customer service representatives on staff to address their needs. At the certifications and health screens, we take a height and a weight. We prick their finger for blood tests to check for low iron. We also we do a brief health and nutrition history assessment. And so once all of that is complete, we also provide the nutrition education, and that's going to be based on needs. So also whatever that assessment might provide for us or information we find out during the assessment, we're going to tailor that nutrition education to the highest need or highest priority in that family. We provide shopping tips. We provide kid-friendly recipes. We will focus on the WIC approved foods for those recipes so they can use, they can get the best bang for their buck in their benefits. We also provide cooking classes to our WIC participants. So we will invite the whole family to come in, the participants, the mom, they come in, using WIC approved foods. We also have a teaching garden here, and we will try and use some of those things during the summertime. And we will actually teach them cooking skills and also ones that can help with like kid-friendly skills. So we have specific utensils and knives that little kids can use without getting hurt. So we provide all of that. And again, like I said before, we customize the nutrition counseling based on their needs. We always meet them where they're at. And then we help them make goals. And then we always follow up on those goals. And like I said before as well, high-risk participants are seen by registered dietitians. So that would be if something was found out through our nutrition assessment, there might be something going on, failure to thrive, if they're not growing properly, or something else that's going to affect their nutrition intake. Then we also provide breastfeeding support. We provide classes. We have one-on-one peer counseling support, which I'll get a little more into in a later slide. And we also provide pumps and supplies. We want to make sure they're as successful as possible on their breastfeeding journey. And then also a big component of WIC is to provide care beyond WIC. So if there's something that's outside of our scope of practice or anything that they're needing that we aren't addressing in WIC, we are going to refer out to that healthcare provider specifically for whatever is needed, whether it's substance use or mental health needs, food banks. We will provide that resource. Okay, so healthy foods provided by the WIC program. I did provide a food list to you guys just so you have that for your reference. But for infants under 12 months, of course, we will provide infant cereal, baby food, iron fortified formula, fresh fruits and vegetables. That's only if they're 9 months or older. The reason for this is we will assess if that family has all the resources to be able to puree the fresh fruits and vegetables for their baby. And then for women and children, of course the children until they turn 5, milk, cheese, eggs, yogurt, iron fortified hot and cold cereals, fruit juice that's high in vitamin C, beans, peas, peanut butter. You can see that list there. Salmon and tuna are for breastfeeding moms and pregnant moms because it provides more of those omega-3 fatty acids and more calories and supports that breastfeeding, the calories that they're needing in breastfeeding. Also, fresh fruits and vegetables. That's the only part of their package that has a monetary value to it. So when they go to the store to redeem their benefits, they have to get the specific food. But with fruits and vegetables, there's a monetary amount that they can spend up to. And I think for, breastfeeding women, it's $52 currently. And I want to say pregnant's $47. And then other women and the children receive $26. I think I have all those amounts right. And now, actually, starting in October, they get to get frozen fruits and vegetables as well. There can't be anything added, but that's a new option, which is great. It'll last a lot longer. But they cannot get anything with like sugars or oils added or anything like that. It just needs to be the fruits and And then they can also get whole grain breads, brown rice and tortillas, and whole wheat pasta. And just to note, foods that are available in the WIC program must be in accordance with the federal WIC regulations. So they have to follow certain regulations to be included in the WIC package. All right, so the value of the packages, these are estimates because as we know, grocery prices can go up and down. But the value of these packages can be anywhere from, as you can see, $60 for an infant that's breastfeeding because they're not going to receive too much between 6 and 12 months, or up to $200 if they are formula fed. And that would include the formula and the baby foods that come with that. So an example would be a family consisting of an exclusively breastfeeding mom with an infant and 2 children between the ages of 1 and 5 can save approximately $345 per month by participating in WIC. That way they can spend that resources on something else that they are offering to, but while at the same time getting the nutritious foods that they need. And it's also important to note that over $200,000 each month goes back into our local grocery stores from WIC purchases. Okay, so peer counseling program. So breastfeeding, we actually have one of the highest initiation rates of breastfeeding here in North Idaho. I believe we're close to, I think it's 89 point something. So we're close to 90% initiation rate, which is great. And we want to do all that we can to try and keep them breastfeeding as long as possible. We have peer counselors on staff, and those peer counselors, the requirements is that they have to be a previous WIC participant or a current. They've had to have breastfed as well, so that way they can really help those moms that may be struggling. We provide free lactation courses. They can be one-on-one, day or evening. We try and tailor that to meet the needs of our participants. And then for postnatal, they can get calls from the peer counselors to offer the support, answer questions. They have, we call it more of a, not really a hotline, but more of a warm line, but they can call after hours if they're struggling and they need to talk to their peer counselor. We also offer latch and positioning appointments and also weight appointments. And what they do at those weight appointments is if they're really concerned and if they're getting enough breast milk out there, if their babies have it getting enough, then they can come in, we weigh baby, they breastfeed, and then we weigh baby again, and we can see exactly how many ounces that baby's getting. So it's just, this was a little while ago. In 2017, though, we were awarded the Gold Elite Breastfeeding Award by USDA. So something to be proud of, and we are still using those best practices. So where do people go to get WIC benefits? So we're located at all of our in our 5 northern counties. We are at every clinic that we have, but we also are in Post Falls and Priest River. We have MOUs. So we are with the Post Falls 3rd Avenue Marketplace, which is their food bank. And then also at Priest River, we have an MOU with City Hall, and we are there twice a month. And then I think wanted to share a success story if I have time. But we had a mom, so we had a nutrition intern, a dietetic intern that came, and she made some zucchini bread with applesauce, and she used the zucchini from our garden. And she made this bread, and so we gave the samples out to our customer service reps so that they could share them with their clients and share the recipe with them. So we had a mom who was an autistic child, age 4. Mom is one of the directors of the Autism Society in Idaho. He eats very little. He has food avoidance. He'll eat chips, berries, Z-bars, and crunchy foods, and is in therapy for his issues. He saw the zucchini applesauce bread samples in the office and pointed at it. I asked his mother for permission for him to have one, and she agreed, but stated he probably won't eat it, which I assumed he wouldn't either. He ate the piece and asked for another. We went over the recipe as he ate a second piece, all of which had ingredients he wouldn't touch in a million years. He then asked for a third piece before they left. Mom will be making this at home and was amazed he even touched it, let alone ate 3 pieces. So she left knowing today that was a triumphant day for her son. So just exciting things when you can make that difference in someone's life. So in summary, WIC reduces fetal deaths and infant mortality. WIC reduces low birth weight rates and increases the duration of pregnancy. WIC improves the growth of nutritionally at-risk infants and children. WIC decreases the incidence of iron deficiency anemia in children. WIC improves the dietary intake of pregnant and postpartum women and improves weight gain in pregnant women. Pregnant women participating in WIC receive prenatal care earlier. Children enrolled in WIC are more likely to have a regular source of medical care and have more up-to-date immunizations. WIC helps to get children ready to start school. Children who receive WIC benefits demonstrate improved intellectual development. And WIC significantly improves children's diets. And WIC also increases breastfeeding duration. So with that, I'm moving on to lactation services because, of course, we want to go above and beyond. This is actually separate from our WIC program, and this is brand new. So I don't have any stats to really talk about, but just want to share what's upcoming. So the program goals, and first I want to start by saying that 2 of our dietitians in WIC are international, let's get this right, international board lactation consultants. So they are the experts in breastfeeding. And so they are really going to be the ones that are in this program and seeing these clients. But what we want to do is make sure that they've got a really good journey breastfeeding and that they can be successful. So we want to increase the community access to affordable lactation services, increase breastfeeding rates and breastfeeding duration in Idaho Panhandle, and also foster stronger partnerships with other healthcare organizations in our community through outreach and referrals. So our referral sources that we will anticipate will be from our WIC program and also from our OBs, pediatricians, and then also referrals from our home visiting program as well, because they serve very similar population. And that is actually the end of my presentation. So any questions?
So Kim, a quick question. So are they given a card that they can use to purchase the items?
Yes.
Is that recharged each month?
Yes, correct. Yep. Yeah, and actually, good point. I don't think I had specified, but when they come in since they come in 4 times a year, when they come in for an appointment, they generally will get up to 3 months worth of benefits from one appointment, unless they're coming more often. If they're higher risk, we will often see them maybe every 2 months and sometimes even every month, just in case what's going on.
No, like,
No.
With the screening test you do, when you're sick, is that repeated periodically or is that just for the insurance?
It's at certification and then generally at health screen, but we do have age requirements and we're not going to poke up brand new infants when they come in. But it usually will alert us to when they are due for that so that we're able to do that. It's usually at certification, then again at 6 months at the health screen.
And if parents choose to not want to do that test, they get record or they have to do that.
Good question. Yeah, they can deny or refuse to have that. They don't have to. But yeah, we like to just we encourage it so that we can follow them and make sure they're doing okay. But they have that option.
With the lactation program, where's the funding coming from?
It'll be reimbursement, so we will be charging 70. Let me make sure I've got that right. I think I put something on your desk too, but yeah, they will be starting $75 if it's out of pocket, and we will also be accepting Medicaid for that, so reimbursement.
Any other questions? Well, I want to make a comment. So, neurodevelopmental issues, most notably autism, is a matter of public health concern to everyone. I don't care what side of the political spectrum you are. You certainly have to have profound sympathy for these parents. I find it interesting that it's not just about vaccines. It's about a lot of things, as Secretary Kennedy has actually stated repeatedly. So for instance, whether a child is breastfed or not directly relates to the incidence of neurodevelopmental issues. You commented on that. Here's another one. Whether it's a C-section, the delivery is a C-section or vaginal birth. Apparently going through the vaginal canal protects the brain. Go figure. Here's another one. Here's another one. The incidence and number and duration of prenatal ultrasounds negatively impacts on neurodevelopmental conditions postnatally. So, if you start scratching the surface, you uncover all kinds of strange things. For whatever reason, we got a whole lot more by way of neurodevelopmental issues. So kudos to you. Let's try to restore health. This is, after all, the mission of a public health district.
Yeah, one other question. So anybody can come for $75, or if they have Medicare, Medicaid, and that. Is there a copay for that too, or no?
Medicaid, no, I don't believe there's a copay for that. It would just, whether they're Medicaid or self-pay right now, we decided not, since it's more of a pilot program, we haven't dove into any private insurances yet.
And then, thank you. And then, what's your marketing approach, just to get that knowledge out, all the pregnant ladies out there, or people with kids that need breastfeeding?
Yeah, our two dietitians have been boots on the ground out there talking to healthcare providers and getting that message out. And then we utilize for social marketing, social media.
And my understanding is we're using existing staff that have other responsibilities, so we
Correct.
don't have an upfront cost on this. We're seeing what the interest would be.
One of my thoughts too on that would be kind of working with current marketing, whoever's working with marketing so far, and to kind of make a nice strategy that could help stand it up even more quickly, because I'm sure the demand would be quite high.
Thank you.
Okay, if we're done there, the next agenda item is the meeting times for this for the board. I put this item on there so that we can have a discussion with input from as many board members as possible. Commissioner Cowley, are you with us?
Yes.
Oh, wonderful. Well, can I invite you to speak first to this issue? What time would most fit your schedule as a commissioner? And as soon as you speak, I'm going to turn to Commissioner Bertland.
For me right now, it's kind of difficult because we have we have one commissioner, for instance, today, we have one commissioner that's out for the week. And then you have one that has to, be at a meeting here and another one here, but it's hard because you got to have that quorum when you're having meetings, and you got to have two. So that's one issue I'm having right now. And of course, I do have another meeting following on those Thursdays, a monthly, with our ambulance advisory board that I have to be present at. I just don't, I don't want anybody to have to change anything because my schedule is just kind of all over the place right now. And that's kind of how it is for me right now, unfortunately.
So you're saying there's no predictably available slot of the entire week or of the entire month?
Right. I don't want to just put that.
How about this time right now? Is this time right now, 1 o'clock on the second Tuesday of the month? Does this work for you?
Sure. I mean, I know that I would love to be able to come in there in person at some point naturally, and I'm trying to get to that point. But yeah, this is not a problem. So
okay, well, Tim,
I'm just kind of.
All right, well, Tim, is this time right now good for you?
Yeah, this is fine. This is better than 2.
Okay, and you've been consistent about that, by the way. All right, well, let's talk to the people that work. You don't work, neither do I, so we can come anytime. Same thing with you, Dr. Pinnock. But Doctors Johnson and Nolan, is this okay for you, or?
Well, 1 o'clock is better for me, yeah, than 2 to 3, because it's kind of like right in the middle of the afternoon. So it's like I have to shift away to then shift back and have patients waiting.
Okay,
So
fair
that
enough.
works
Dr.
better.
Nolan?
I mean, this time could work with planning ahead. I'm a fan of early morning meetings, like 8 a.m. Doesn't bother me.
Well, I hear you. If I may speak for the commissioners, though, I think their habit is to meet in the morning. Is that correct, Tim?
Yes.
Yeah,
Okay.
the morning is not going to work for the commissioners. I mean,
Fair enough.
that's their normal, at least the ones in Bonner County, but I think they all do that.
That's fair.
Yeah. So for the sake of the commissioners on the board, I think we should accommodate at least an early afternoon meeting. But I respect your position.
Yeah.
But you're going to get trumped by the
I mean,
commissioners.
all times similar to.
All right, so
Commissioner
I'm going to
Cowles.
make
All
a-
times have interaction with
All
something.
right, so I'm going to make a motion. And that is that moving forward, the PhD board members will now be the second Thursday of the month at 1 p.m. It has to be a different person?
If you're
Okay,
gonna
I'm
make that
sorry. Will
motion, you have
Will
to
somebody else make,
Sure.
I'm sorry?
If you're going to make that motion, you need to step down from the chair to make that motion.
Oh, okay, well then, will someone make that motion, pretty please?
I'll make that motion. Make a motion that we meet second Tuesday every month at 1 o'clock.
Do I hear a second?
I second that.
Oh, did I say Tuesday? Oh, I
No,
apologize.
Thursday,
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 Thursday. Today is Thursday, isn't it?
Yeah. Yes.
yes, Thursday.
Have a fiscal report. Month end just closed yesterday, or reports became available yesterday, which does not allow enough time to prepare and review those reports. So they could be presented a month in arrears.
And, fine, do you have, that's okay with me.
So are you saying
But thank you for
every
bringing
month,
that to our attention.
the second, was it the second Wednesday? Or is it what was yesterday again?
Well, yesterday was, what's today?
Yesterday was the
Yesterday was
second
the
Wednesday. So
Yesterday was the 8th.
is it the 8th
But-
of every month? Or,
No, it's not. It's,
Okay.
it's based on the number of days.
oh,
After the 30th or the 31st. And then we also allow for an extra day so that 2 modules will settle and the numbers will match. So
it's important.
it is important.
Well, Christine, thank you for bringing that to our attention. I would put that issue sort of in the same category as every year we go through this ritual of going from daylight savings time to standard. And there's always a little trauma with that, but after you overcome the trauma, then life goes on. So considering that the second Thursday, 1 o'clock accommodates the commissioners, I would still argue in favor of going with
Can I
that.
just ask one more question on that? So you're saying that sometimes it would be a problem, sometimes not, just depending on the days, how they line up. Like sometimes if you have an extra day, then we're good. Yeah.
I'm not comfortable with just an extra day,
Okay,
not at all.
that's fine.
By the time, because there's a lot of prep work,
Mhm.
particularly when it comes to the cash flow and the restricted programs.
Mhm.
Those have to be populated individually. So it's not a matter of pushing a button and pulling the reports, because everything is data managed, manipulated, put in Excel spreadsheets. So we don't have a canned report.
Mhm.
So I think that's still very tight to ensure presenting something with accuracy.
No, thank you for
But
that.
you would have a whole month to still prepare.
If we're reporting a month in arrears, yes.
Right, and that's fine.
Thank you.
Any other comments?
Thursday, last day of the week, regular schedule.
Well, I don't know. I put it to Commissioner Cowley, did this day right now work? And she said affirmative. So without exploring the universe of other options, I went with the simplest approach. Would you like to make another motion? Yeah, it'll work for me.
I would say we go with Commissioner Bertling's motion, and then we see after a couple of months if we need to, if it's working.
Well, we can always revisit, of course.
Mhm.
All right, did we get a second for the motion?
I seconded, yeah.
Okay, so let's have a roll call vote, please.
Glenn Bailey,
Yes.
Dr. Johnson,
Yes.
Commissioner Cowles,
Yes.
Commissioner Bertling,
Yes.
Dr. Nolan,
Yes.
Chairman Fletcher.
Yes. Okay, the motion passes. Next, item 8 has to do with a review of legal services. Dr. Nolan.
Okay, so I was looking at legal service, and just like with talking with some commissioners too, and just looking at I don't think that there's been, at least recently with the current board, been much guidance as far as how we want to interact with legal services as far as that. So it's been kind of like more of it appears to be like an absence of guidance and board desires on how to interact with them. So, and one of the things in overall in looking at, the budget and time, because as everyone who's interacted with legal services before, it always comes with an invoice. And so I wanted to discuss that and kind of figure out, one, like we've had a shift, like I got a report from finance, thank you, that kind of looking at our legal services, and we had a big jump this year in legal services from previous years. And so wanted to figure out, so how do we manage successfully? I have reviewed our legal services contract currently. It looks very standard contract, but it's invoice billing versus there's different options with legal services. You can do invoice, or you can do what you'd say like retainer. And so I know most of the times when I've ever acted in business, it's been a retainer model. What's nice is that that you're not going to be getting a bill for 5 to 10 times what you're expecting, because they hit the retainer and they say, if you want us to do more, you have to give us more. So my thought would be several things, but would be, and to propose shifting from invoice billing to a retainer billing model, so that we have more knowledge on what our legal interactions are going to be. And then what we do is the board can authorize additional retainer as needed based off of that. And we can then review who's used the legal services. I think part of the policy that I would like to put forward, and whether it's more of an ongoing conversation while we develop it, would be who and which departments can evoke legal services. Is it every single person, or is it just the department head, or how is that going about, where they get a call and then we get a bill, or whether an email or a bill? So I think kind of looking through that. So because there's been a mark just this year, fiscal year 2025, it's not done yet. Q1 through 3 has had a significant increase in legal services, and those aren't usually reimbursed by by fees or staff, basically like you would for permits and all of that. So that's one. The other one would be is really.
I was just going to ask
Yeah.
you, can you share the numbers, the difference in the previous years? And this
Yeah,
year?
I think that's all open meeting stuff. Is that right? So, yeah. So I think that according to my report, fiscal year 23, I asked for some years back just so we can kind of see what it was about 7,100. Fiscal year 24 is about 2,000, 1,995. Fiscal year 25 was about 1,836. Fiscal year 2025 was 31,000. So it was a factor from the highest. It was actually like over 4 times the highest previous one in 2023. So that's a fair bit of funds and money. And so I think that, we kind of need to manage that well. And again, if there's a specific need that we must do and we have to allocate our resources, then we do that. But I think we need to kind of work together to plug all the holes we can as far as where the money goes and how we utilize it. And if there's a less expensive way to do that, then we do that, as long as we're actually complying with all the stuff we're supposed to comply with. So, so one of the things, I guess, to kind of summarize and not just go here is would like to figure out, and this could be part of a discussion, and maybe the director can talk to us a little more about what policies have been followed, to if they can call them that. I don't know if their policy is official or not, on who can evoke legal services and not in the different departments. Would you mind commenting on that, just as far as?
To my knowledge, there's not a policy in place. Historically, our need for legal services was very limited, typically related to a rule set that we had prior and periodic contract review that with various vendors that we have. It certainly has increased significantly this year.
There is a policy, and I haven't looked at it recently, but it does state that when legal services are needed or required by a division or a program, then the approval comes through the director.
Okay.
And that is true. I guess in regards to board activation versus administration activation, and Christine, I guess I don't do this. I don't know if Christine can do that.
I don't recall, like I stated,
Yeah.
I haven't looked at it recently, so I don't know if it speaks to the board reaching out internally. It must go through the director first.
Yeah, that makes sense. And
My thought is that you're actually bringing up a good point, that there should be clarification and especially when numbers can change significantly and costs. I think there should be some tighter control or management or direction in some sense that should be explored.
yeah, and that's whereas what I was thinking of is if we put it into a retainer model and we say, okay, that one of the main reasons to ask this was in my research for retainer model, what I'd say, like, what would be a reasonable amount like that we've done, but then such a dramatic increase this year that we then say, okay, what would be like a six month standard usage? First of all, we need to figure out why is there $31,000 this year? Is there other action and stuff like that? And that might need to be, if some of it's related to any kind of litigation, that might be like an executive session item or that kind of stuff. But if it's not, then it's not an executive session item the way I'm reading it, and all that. So, but the idea is figuring out that, and then we'd say, okay, if, say, just for an example, say if that $3,000 was approved for a retainer fee, that would satisfy almost half of 2023's and all of 2024, 2025's. And then if there was a need for more than that, then the director could come back and talk to the board, and we'd say, okay, this is our proposed additional need that we have. Then the board would then approve an additional retainer amount, which then would because that way the retainer fee I like, because it's not like every single little interaction needs to be micromanaged, because that then can encumber whoever's needing to use services, whether it's environmental services or community services or the director's office. But it's an amount where at the end of every retainer being consumed, we look at, okay, by department, who used it and who evoked it. And that way we can just kind of assess, okay, cool. Do we need to adjust our amounts? Why did this increase so much? Do we need extra in-house training so that they don't need to go to legal as much or not? So that way we can just kind of manage our funds and our systems a little bit more. So any thoughts or questions or input on that? Any of the commissioners online?
Mr. Chairman,
Yeah.
if I may, one thought that I would have on that is that there are certain business operations that we have with contracts where timeliness is the matter, or is of importance.
Mhm.
So if we could have a separate amount for standard business occurring at the health district, because as my review of legal costs, a lot of that has been driven by board discussions and board topics. So if there was a way to differentiate between those pots of money, because if we have to wait for a next board meeting in order to ask for an additional allocation, if there's a certain issue that's administrative issue or contract issue that's arisen, that might.
Well, Director Kettner, we're thinking alike. So in there would be not a different pot, but there would be an emergency authorization process where 4 of us could get on a phone call and do an emergency authorization for more if it was so urgent as needed, where and also part of that would be looking forward and saying, hey, are we looking in the next 2 weeks, say if we have $1,500 left in the retainer, are we looking at maybe needing that much time? Because we know what the amounts are per hour, and be like, hey, it looks like we might have 5 hours of legal time. Looks like we might blow past our retainer in the next 2 weeks. I should probably by the end of the week have a call with the emergency team to see if we can get it approved, because this is so urgent they can't wait for a week and a half more, which those happen. And so, but the idea is that would be to have that, but that way we can really make sure that it's a structured thing on that. And as far as you're mentioning that the board generated, I have, other than legal services having reached out to me to the whole board, I think, just to say, hey, you guys want to learn what we do. Other than that, which I think everyone got that email, no, I don't think any of us that I know of have had any interactions with legal services that would evoke invoices, other than I'm sure a reply might email invoice. But other than that, so can you express more what you mean by board generated, just so we can kind of track on that?
There were, and I believe it was prior to you coming on the board, but there were a few
Okay.
issues that went before the board where a number of members of the board expressed concern or interest in legal input. And so that generated requests for legal to weigh in, whether some of those at that board meeting went through me, others, to your earlier point, went directly from board members to legal counsel.
Okay, so then that would also be part of the policy that I was thinking needed to happen, because I was wondering if that was the case, if board members were independently generating, and that if board members are going to reach out to council, then it needs to be brought forward to the board in general, because again, it's all about that invoice that comes and needing to explain why. Because so I've heard stories of other institutions where somebody got excited about calling the lawyer because they just thought they had questions. The lawyer was very fun to talk to, and they ended up getting bills for many thousands or tens plus thousands of dollars, and they didn't realize that they were on the clock the whole time. So staff couldn't generate, even inadvertently, bills if they're not a strict policy of saying, if you're going to interact with them, then you need to have approval, and this is how you get approval. So it's just very clear, and then that way the staff don't get stressed out from thinking like, oh my gosh, I generated this bill, I didn't realize it. So I think that's really important. And then also we can review and audit the bills to say, hey, whether or not we agree with the actual billing itself. And that's something you can do with legal too. So you don't have to accept everything you get billed on. So I think that what is it exactly is on this? I would like to.
Right, if I may say
Yes, go
one
for
quick statement, Joel, I didn't understand what had transpired, and so I mean, if a single board member can reach out to legal and maybe drive an issue that's of their preference, then that's almost like an individual taking control of legal influence in the board, and I definitely think there needs to be some limitation and control on that. That's and so you bring up an excellent point.
Yeah, thank you. So
At
my
this juncture, if I may
Yes.
actually add, so I have taken the opportunity to actually study in detail the invoices of Lake City Law.
Okay.
Now, I'm going to be assiduously careful about not saying anything that will be disturbing. We don't want to disturb. But my general observation is that the reason the legal services quadrupled in cost in just the last 9 months is due to triangulations. Triangulations. In other words, you have administration versus board, you have some board members versus other board members, and you create this, you generate legal activity, which ends up costing money, and it's not very productive. It causes some measure of discord, and I don't think either of those is medicinal in the long run, which I believe is your point. So the genesis of the uncontrolled legal costs is due to there being a lack of, shall we say, control. And I think that's what both of you are referring to. So it strikes me that we need to develop a mechanism of control. I'll be quiet.
If I may add to that, one adjacent topic to that may be how the agenda is set. Because from my observation, some of the differences of opinion came about because board members convened and everybody didn't know exactly what the topic was, what the discussion points were. And so that led to confusion and then a desire to invite legal to weigh in. So I think as a component of this, that may be valuable. Because I do know that I'm just working with Jessica. It's a bit of a scramble the last 7 days to kind of get the agenda finalized and making sure that everybody's on the same page. So if there was a more structured manner in putting that together, I think that would help with this as well.
Okay. Director Kettner, you're saying that the agenda assembly is generating revenue, like invoicing from legal?
It can when the agenda changes several times and the direction of the board is for legal to review the final, or to review the agenda.
So we have a direction to review the agenda from the board?
Well, it was sort of commented on 6 months ago. That is not written in stone. We can reverse that.
So my understanding in review of the documents is that that is an option, but not a requirement, my understanding. So that's something that I think we should look at. I'm not sure if potentially the with the commissioners, they might be a good person to check. Like, do the commissioners also have in-house legal because the county prosecutors are the legal. So that's a little bit different story. I don't get necessarily a bill for everyone that I know of. But do commissioners tend to review all their agenda items with legal? Is that?
No, we pull
No.
out certain things.
Okay. Thank you. So I think unless there's something that is thought to be of need of legal review, I don't think a blanket review is necessarily fiduciarily good idea. That's my thoughts. And again, if there's something that anyone looks at and goes, hey, this might need legal review, then someone can present that. We have to make a mechanism to say, yeah, that needs to be approved, to be like, sure, let's do that. I think the carte blanche is costing more money than it should on that level. So as far as I don't want to belabor this topic too long. So there's a couple ways to move forward. One would be, being that there's not a written specific policy. One, I think, would be to review the existing policy so that we can see where that is, and then present an amendment to that policy. But initially, what I would like to do from today, just simply, unless someone has any comments on it, that's fine, would be to renegotiate the part of the contract without the whole one, of moving from a invoicing to an approved retainer system for billing with our legal services that we currently have a contract. Not changing the rest of the contract is, well, most of the rest of the contract is very straightforward. But that way we could then say, okay, but for the rest of the year, because we've kind of spent 4 years worth of legal so far. So I think for the rest of the year, it'd be best to try to spend almost none unless absolutely necessary, which it probably will be, but hopefully minimal. So that's my thoughts on that. And so that I would make a motion to renegotiate our legal billing services to a retainer model versus a invoicing model.
Yes.
I have a question.
Yeah.
When you're speaking about a retainer model,
Yes.
are we discussing basically we would be paying the law firm, say, as an example, $10,000 a year? And that's what we would be paying, whether we use up that total 10,000? Or is there a reconciliation at the end to where we are actually only paying actual legal costs?
That's an excellent point, and I'm sure you're matching up columns and what that equates to. I think the idea is what I've seen is that, and you can let me know if you know of any statutes that make this not okay governmental wise. But the idea would be is say, okay, we approve $3,000 for that. Just example, just a 3 is an awesome number. So then the idea is that say if $2,700 was used by the end of the year, there would be a balance left that would either roll over to the next year, or we can make an agreement if needed per governmental stuff that it gets refunded at the end of the year if there's a statutory requirement on that. So that it's basically what it is. It's they hold a stack. If you already know, my apologies, but they hold a stack of money that they then bill off of, and they still send you invoices for it. But then when they hit the end of that stack, they stop everything and they don't do any more work, so you don't incur any additional costs. And so if more work is needed, you then say, sure, we will. That sounds great. We'll give you another 3,000, and then it may take them 2 months to get through that 3,000. But it's a way to have them hit stops. That means that it doesn't keep going on and ongoing, and then it allows you to actually have direct control of the total amount spent. And if you're like, ooh, we actually ran out of money, we're going to say you can do 2 more hours, and then that's all we can pay you on this topic. Please send us your final, and that'll be good enough. So that's those kind of interactions. As per the contract, it's for specific, more daily operational stuff. It's not for individual litigation issues, because those require separate contracts. And so almost any litigation issue, unless they have a different governmental interaction thing, almost any litigation issue requires a retainer from any law firm that I've ever heard of. And that may not be if they're working with the government with a big credit card or something. But the idea is that if you get into a law thing, they're like, okay, we need to, and this contract requires you to pay us $10,000 retainer. We bill against the retainer, and then once that up, you have to pay us more in another chunk, and then we bill against that. So it's a common legal thing on how they actually make sure they get paid.
So I do have concerns.
Yeah.
And typically, the state does not allow for prepaid expenses, and we do follow state policies. And the only time that prepaid is allowed is when it is a profession where it is common. My concern also is if we pay a certain amount of funds, it would need to be reconciled to actual costs by the end of the fiscal year.
Absolutely.
And I state that because that is going to feed into all programs. So we don't want to be paying an excess amount for a service that we did not receive.
100% I agree with you.
Is there?
Joel?
Oh, I'm sorry, Mr. Chairman.
Go ahead, and then I want to make a comment.
Is there a way, Christine, where maybe we could functionally have what Joel is proposing in the sense of money reserved to an account, not given directly to the legal firm as a retainer, but reserved to an account? This is the account we pay out of, and then at the end of the year, if it's not used, then it still stays here. It's just that we were functionally paying out of that account that's here, and then you could reconcile it that way. The issue potentially with this is that it doesn't stop the law firm from doing additional work and sending a bill. So they often have tracking software there's very sophisticated legal tracking software where they click on and off, and then it keeps track of how many hours are on that retainer bill, and then it comes up and says you got to stop, and literally they can stop like mid document. They're like, okay, done.
putting it on the side until they get a final approval for another person. If it's a budget here, we could get an extra $4,000 bill on a $3,000 retainer that we're holding because they did all this extra work that was probably very legitimate work, but it wasn't checked with us as we actually wanted to keep going on that. So that's the issue is, and it is extremely common. So it could fit that criteria. We'll just have to check and see if it does. Obviously, we don't want to do something that's not allowed by the state, but if it is allowed, because legal, any interaction I've ever business-wise had with legal has required retainers. And so that is a one field for sure that's extremely common. So it might qualify. If it doesn't, it doesn't, but it does. So then that could be something we do. And then, like you're saying, everything would have to be fully reconciled and matched. And they tend to send an actual invoice as if it was individually billed every time they draw off your retainer. So it's a basically an account payable. It's technically yours until they draw off of it.
I'm going to take this opportunity to make a comment. Thank you, Dr. Nolan, for bringing to our attention that something needs to be done to wrap our arms around legal expenses. I think we can all agree to that. Now, you put forward an idea, and cogently, Christine has sort of brought up the point that it might not be so easy. And I respect her position. I understand her position. I think it's a strong position. So what I would propose is that we not try to solve the issue of how we're going to structure our legal services in this meeting at this time. It's just too complicated. And it's too many things going on. I want to hear from Christine. I mean, I think there are ramifications to the budget, I mean, that are vital. So I guess I can't propose things, but you might consider maybe putting together a committee, a legal committee of board members who would study the issue, converse with stakeholders, and then come back at the next board meeting with now a well thought out plan as to how to move forward. Does this make sense?
Mr. Chairman, my question would be, is it an annual contract in January through the fiscal?
Oh, I don't know. What does the contract say?
I think it's ongoing. I don't think it's a start-stop contract. It can be, and it
It's
can be.
probably a 30-day out clause or something.
I don't even know if that, but basically, it can.
They will charge us this rate.
If there's a rate given, and if they need to change their rates, they're probably going to come to us with a new contract at some point. And then it's an invoice based off of time consumed, based off of different personnel, whether it's paralegal versus legal versus super legal. You know, some of the lawyers are more than other lawyers and all that stuff. So we can do that. Yeah, so that could be part of a renegotiation process, but
Well,
Yeah.
again, actually, Glenn's question is cogent to why I'm saying I don't think we're going to settle this in this meeting. There are a lot of unanswered issues that need to be considered.
Yeah.
And yet another one. Thank you, Glenn. I mean,
yeah, it's a good one.
any other comments, or do you want to make a motion, or
Yes, I'm just trying to discern what motion.
It's an action item.
well, if we okay, we can table it, but if I appoint a subcommittee, a legal subcommittee that's going to drill down and study this, does the formation of said subcommittee require a motion? Or can I just do it? If I can just do it, then I'll just do it. It would make me feel good if it was a motion seconded and passed.
Yeah. Well, I'm okay doing that. Make a motion to set up a legal subcommittee to work on legal interaction policy, update of our current legal interaction policy, and then what also would work good with finance to make sure that everything is working well, and in order to be good fiduciary management of our money and funds. And so that way, I think what I like about that is that everyone can know a consistent thing that we can look at and say, okay, how do we handle this? Like the board members, we can all do that. You guys can do that. Something that we can point to all of the department heads and administrators. And so I think that would be great. It would just simplify our whole thing. So I make a motion to, Jessica, make a motion to start a legal services oversight committee to develop to review and develop our policy and work on renegotiating the contract after that policy to match the policy we make. So
We'll have discussion. Let's hear a second. And after we have or are you wanting to second it? You can, after it's seconded, and then we'll have discussion.
I'll second the motion.
Okay, go, Peggy.
So I think we can correct. So I would propose to know that we have no expertise at the meeting. My understanding, yes, is that we could add an item to the
Peggy, turn your microphone on.
It's on, I'm just not speaking into it. That you can add an item to the agenda, but it needs to be done at the beginning of the meeting. And the rationale for doing that needs to be stated. I could be wrong, but that is the procedure I have been familiar with. And you're going to add to the agenda. So I don't know.
Well, thank you for that comment. How does that relate to setting up a legal subcommittee?
there's no new agendas currently. This is one that was already on the agenda item.
We are actually going to, it is on today's agenda.
This is on number 8 on the agenda.
Actually, it's item 10, sort of relates to what you're talking about. So if you want, it's a very important point you're making, Peggy, very important. Can it wait until item 10?
Sure, I would like to apologize because I knew the date for the meeting was changed, but did not realize it was at 10 o'clock, so I would like to apologize for my tardiness.
The thing is with number 8, with legal services, I mean, really, we should have had it as it is as an action item. So we could make a committee.
Correct. That would be the action, to make a committee.
Mm-hmm.
And then, obviously, there's a lot of detail that needs to be flushed out. And we're not going to settle it in this board meeting, which is thus the purpose of said subcommittee. So we have a motion and a second. Any other comments?
Tim, is that amenable to you?
Yeah.
Okay, thanks.
Okay. Hearing no other comments, roll call vote.
Glenn Bailey. Dr. Johnson.
Yes.
Commissioner Cowles.
Yes.
Commissioner Bertling.
Yes.
Dr. Nolan.
Yes.
Peggy Kabala. Chairman Fletcher.
Yes. Okay. Again, thank you, Joel, for bringing that topic up. Now, the next item, number 9, is actually a related topic, liability insurance. I say related because it has to do with lawyers. Dr. Johnson, you requested this topic.
Yeah, yes, thank you very much. I apologize for not being here last meeting at the end to bring this issue up at that time, but I think I'm not aware completely of the liability that is being offered. Whether or not we fit under the ICRIM or not, and we may, but at the same time, if is that adequate, and or should there be an exploration and consideration to additional liability, et cetera? I mean, in other words, I'm just bringing up the issue, and I have as a sub A there a generation of a subcommittee to explore. I mean, since it's related to item number 8, I mean, it certainly could fit within that same subcommittee because it's all related to legal issues. But that was my point and my purpose for bringing it up. That's, I really don't have any other comment on that.
So let me see if I can understand what you've said.
Mm-hmm.
What you're saying is, and frankly, this is not a new topic. As a matter of fact, there was a board member who was sitting on the board 6 months or 8 months ago who brought the same topic up. And we were assured at that time that we have adequate liability coverage. I gave it no more thought. And to be quite honest with you, it really wasn't until Dr. Pennock came along and he started scratching underneath the surface. Well, what exactly is your liability coverage? Is it adequate? And the more you scratch and sort of say what's going on, the more you realize there are more questions than answers. So frankly, I think you're bringing the topic up is timely. And so thank you for that. And then if I understood you at the end there, are you suggesting that since we've already sort of established a legal subcommittee, you would fold into the portfolio of business of that subcommittee this issue of liability? Is that what you're suggesting?
I would propose that. We don't need any more committees.
I know. So let's just have one committee that deals with just the general topic of legal things.
Right.
Okay. Are you making that a motion?
Yes, I would like to make a motion that. Oh.
I mean, as far as insurance goes, iCrimp for our county has been very good to work with. And as long as you do things by procedure and don't step out of that, your lane, so to speak, I mean, if you do and you want to, let's say, I'm just going to use an example. If you want to fire someone, you don't have all your ducks in a row, they might make you pay a $20,000 retain for that. If you do have everything in line and you get rid of, that's $5,000. And they'll waive that. So it's a very good insurance. And I'll just leave it at that.
Well, that's an important piece of information. And certainly as we explore the parameters of our liability, that the input you just gave, I think, is vital.
Mr. Chairman.
Well,
may I have a comment?
Go ahead.
Go ahead.
Go ahead, Tim.
I was going to say, there's a county that would really like to get back in with iCrimp that is having a tough time with that. So I'll just leave it at that.
I'm sorry, say that again. I'm not sure.
I think what he's saying is that if you don't do things the way iCrimp wants you to do, then it can be a trouble for you to be able to be protected by them. Is that correct, Dr. Commissioner Bertling?
Yes, you need to do things a certain way. You need to stay, let's say, in your procedural lane of what you're doing.
Well, again, your input is cogent. Thank you. I mean, in other words, the insurance company is setting up rules of the game. You have to follow the rules of the game. Amen. You can't just go do whatever and then expect them to cover you.
That, and if you have any questions, they have people you can call and bounce things off of, and they will tell you whether, you're a little bit getting a little sideways or not, or you should,
Well, this
bring
is
things
not
back
uncommon. I mean, in my years of practicing medicine, I can tell you that the law firm that my old company we had, and it was also tied in with the insurance policy, we had yearly in-service. And they told us how we had to go about conducting ourselves so as to maintain coverage. So this is not new to iCrimp. I think this is the insurance industry. Heck, if you have automobile insurance and you have a habit of driving while drunk, it may have consequence. No, I hear you loud and clear. Very good.
Okay.
Any other comments?
Mr. Chairman,
Yes, ma'am.
I would recommend that at the next board meeting, we invite Risk Management, Division of Administration Risk Management, to present to the board the coverage provided by the state. I think that would be very informative for the board and assist in any decision making.
Right. I couldn't agree with you more. As a matter of fact, Eric and I caucused on this topic just before this board meeting, and he was making exactly the same comment. And the joint agreement, and thank you for saying what you just said, if this subcommittee goes about doing its business, then next board meeting, when we come back with certain recommendations, absolutely risk management will be here. And not only risk management, but ICRIM people. Or,
If I may, I believe-
Sure, go ahead.
Idaho Risk Management is Idaho Self-Insurance Program for state income. The Panhandle Health District, we, by statute, we're allowed to participate in that. I think ICRIM is similar. It's the counties that are self-insuring. So we're not part of ICRIM, but it's a
You're
similar
not.
self-insurance program. It's the state entity, state self-insurance that we call it. Very
You know, as we
similar.
peel back layers of this onion, the less I know. All the more reason we need to investigate what in the world's going on. I mean, I'm not even going to pretend to know what the hell is going on. But Christine, I promise you, I'm going to make a personal pledge. We're going to have the stakeholders at the meeting when we come back, and we'll have people who know what they're talking about talk. Will that make you happy?
That will make me very happy. Thank you.
Thank you.
Mr.
Dr.
Chair.
Pinnock.
And I'm sorry if I'm the one that opened this can of worms. That was not my intention. But in my past, I would have a physician contract and I would be given a certificate of insurance, which would guarantee professional liability and other liability. So I asked for a certificate of insurance, and apparently there's not one that exists. So I was just interested in having some affirmation that I was protected under the statutes, that I had some indemnification statement, and that I had assurance that Panhandle Health was opted in to the risk management program. And therefore, the MOU, which I think the board has seen, came out. And admittedly, it's not the clearest of MOUs. But that was my intention, was just to get those assurances in place. Because it's no secret to the board that liability protection is as important, more important to me than compensation.
May I speak to that
Oh, yeah, sure.
at a high level? I think this is where it would be very important for risk management to present, because employees are covered. They do have protection by the state through risk management, assuming that they don't have, that they are not doing, that there's no wrongdoing or anything illegal. So there is protection, and we're also protected up to the tort claim of $500,000 as well. And speaking to indemnification, entities in the state cannot indemnify another party. It's against statute. So again, very important to have risk management do a presentation.
Amen. 100% agreement. And they will be here. And whatever recommendations come forward will all be in accordance with statute. And we'll have a lot of opportunity to, in fact, I promise you, between now and the next board meeting, we will be talking to you. Beware of what you ask for. Okay. All right. So we have a motion and a second. Any further discussion? Okay. Roll call vote. Well, please state the motion, please. It's so much time has transpired. Either Jessica, you do it, or
I would prefer to not disagree. And Jessica, did you write it down?
The only motion that I have was from the first subcommittee, and then I don't.
Oh,
I
okay.
didn't catch everybody.
Okay, I would like to propose that the topic of liability insurance be an additional exploration of the legal subcommittee that we have appointed.
Do I hear a second?
Yeah, second that.
Any further discussion? Roll call vote?
Glenn Bailey,
Yes.
Dr. Johnson,
Yes.
Commissioner Howell,
Yes.
Commissioner Bertling,
Yes.
Dr. Nolan,
Yes.
Eddie Kabbalah, Chairman Fletcher.
Yes. Okay. Moving on to item 10. Dr. Nolan, this is another topic that you brought forward.
This will hopefully be very quick, hopefully.
Would you explain what you have in
Yeah,
mind?
I think just in all of us coming from, I guess we call it civilian life or whatnot, and that I've thought that I did a summary of executive session statutes from state of Idaho for open meeting laws and thought it'd be useful just to have a reference guide that is included with every agenda so that we can quickly reference it and not have to go look up stuff if we don't remember the exact part. And then we can state it accurately in a timely manner. It's mostly just to help with the appropriate calling of which things, if that needs to happen, which it often probably shouldn't happen that often. But that way we know exactly that we're utilizing the exact part of the Idaho statute and we're complying with open meeting laws. So just I wanted to make a motion that we include, it's really just including information along with the agenda so that we can all look at it and just easily reference it. Yeah, just for reference. And that way, hopefully, lets us move along more quickly if there's and clarify issues. So, just
Do
basically,
you have language?
I do. I presented it to Jessica. That's actually, I think it might.
Is it on tab?
Yeah, it's in tab 3.
Thank you, Jessica. And if it needs to be updated, then that is fine. I just went and looked at the actual statute and kind of broke it down. Page 21 of the packet. And so basically just kind of a quick summary of what it was with the code number, because we need to reference the code and the number. Then you need to reference the section and subsection anytime that's evoked. So I figured that this would be a way for us to, and then there's a brief explanation of kind of the meaning of why you would evoke that section and what's okay or not. So example would be, if we were saying Idaho Code 74206, Section 3, and I actually combined it on each one so that you would have the full thing that you need to read to legally. So say if we were doing real property acquisition, Section 3, then you'd say, okay, but under Idaho Code 74206 1C, we're going to discuss acquiring real property not owned by another public agency. And then we go into the session. That kind of thing. So it just makes it easy so we actually know what to say, so we're doing it legally. That's the idea. And if anybody sees any issues or wants to update this, that I think we can make sure it's accurate as accurate can be. So I please invite.
I just have
Yes.
a few questions.
Mm-hmm.
And again, I'll put this out to the commissioners that, you know, I'm more familiar.
Can't hear Peggy.
Oh, sorry. I wanted to ask commissioners or others that are more aware about executive session. My experience with executive session is that we actually had it posted on most meetings. And if we needed to go in, it was there. Because I thought there was a rule involved that you just don't go into an executive session. Is that correct?
My understanding is that I think that there is a way to go into executive session that wasn't posted, but it's very, very specific. And that's an additional item that I was going to hopefully add in as a reference sheet on another one. But this was just to try to keep it straightforward. This is if it's already listed as a possibility. I think what you're saying was mentioned by one of the other board members that they do that where they just put it down as a possibility on every item in case it's needed. I think unless there's a reason or a statute that blocks it, which I don't think there is, then I think that's a fine thing. But that would be a policy we would need to let Jessica know that we want to do that on our agenda items. But then if we were to utilize that, this sheet tells us how to utilize it accurately without making a misstep. And my understanding is that if you misuse executive session out of no ill meaning, that if it becomes to the knowledge of the board that happens, then there is a curable time, which I believe starts when the knowledge of it being misused, and it's like 30 days or something. So it can be cured if there's a problem. So it's not like it's like a forever thing, but you do need to cure it. And that cure it only happens if someone realizes that it was done inappropriate. And so this would hopefully minimize the need for any cures moving forward in the future, would be my hope.
Have a guide, but we would also be posting executive session.
Absolutely.
on the agenda.
Yeah. At least that's my intent on it. But I'm not chairman.
Any other comments? I'm going to have a comment, but I want everyone else to comment first. So please go for it.
Page 22, the motion and vote. This is actually information reminder. I think this would be important for us to have readily available in our package each time. So that we can give clients.
Any other comments?
Thank you, Glenn.
Well, hearing none, then I'm going to comment. So I've had I've had no formal education in open meeting laws, and my education on this matter is on the fly. So that makes me a compromised individual, and I admit it right out front. That being said, I was making a presentation to the Bonner County Board of Commissioners about 2.5 years ago, and in the midst of my presentation, one of the commissioners said, I think we need to go into executive session and bring risk management in. Okay, and it happened. And so we got everyone out of the room except for risk management, and I proceeded to say what I said. So at least it's possible to actually go into executive session on the fly, or as they say in the jargon of football, it's an audible. The quarterback sees that there's a certain formation of the defense and the quarterback wants to change the call. It's an audible. And then we had the whole issue of the medical director, and we floundered about and wondered whether we could actually move forward. And someone did some internet search and came up with the requisite code that in fact directly relates to the issue of, can you make an audible? And it's true, you can make an audible. And after that meeting, because there were lots of accusations and counter accusations, I called a couple of buddies of mine who happen to be commissioners and they sit on boards of health. And they affirmed to me that indeed it's possible to do it. And in fact, Health District 2 has a smaller version of what Dr. Nolan is suggesting. Instead of the whole doggone thing, which is one option, what they do is just at the bottom of their agenda. This is an example of what Health District 2 does. And it reads, executive sessions may be held pursuant Idaho Code 74-206 as needed during a regularly scheduled meeting. The purpose of such a session shall be announced at the time they're called. And so that's how the statute reads, and that language is embedded on the agenda. So it's kind of a miniature version of what Dr. Nolan is suggesting.
So what it sounds to me that what that does is it basically does what Peggy was saying, rather than listing it under each one, saying on the agenda that we're announcing that. And then this would actually allow you to know how to go into the executive session.
It's just more detail.
But that doesn't allow you to know how to go into it unless you've memorized this, which I know I haven't fully memorized it yet, probably by the end of the year.
So it seems to me that we have the minimalist version, which would be this, or a more maximalist version, which would be Dr. Nolan's. I don't have heartburn over either one. Now I've said my piece. Commissioners, do either of you want to weigh in on this? This is what you do for a living.
We have exec session. We have one in the afternoon with our HR director. That's always on the agenda. Sometimes we use it, sometimes we don't. We have exec session on with our attorney, and sometimes we use it and sometimes we don't. So that's where we're at. We hardly ever go into exec session in any other time other than those. So that's all.
Okay, thank you. Dr.
And
Crowley?
honestly, the only time we go into executive session is when it's already on the agenda and we know what's going to be coming forth, whether it be with an attorney, or maybe it's personnel, but we know ahead of time and it's on the agenda of what executive session we're going into.
Okay, thank you for that. So what I'm hearing here is that there are different, may not even be statutorily defined, but at least there are different habits. And it could be that different counties have different habits, and that's fine, by the way.
So one thing Commissioner Cowles might be saying, and you could correct me, but is that this kind of reference sheet isn't needed per se if it's actually listed with the actual statute and everything that would need to be written on that line item of going into executive session. Is that what you're?
Yes, as long as
Mhm.
as long as that executive session statute is on your agenda and you know it's coming up on a meeting and then the public knows that, you're fine. As long as that's listed on the agenda. Yeah.
Okay.
For that particular statute, whatever, whatever it pertains to.
So then this would be more potentially useful if there was a need for an audible or a clarification, just to have it as a quick reference. So we don't spend time looking it up.
I'm going to make a recommendation. In 2 weeks, we're going to all have this board in service. We're going to spend a whole day talking about this. My friendly recommendation, Dr. Nolan, is that we table your suggestion until we've all had an opportunity to undergo that training. And then bring it back. I think you're making a cogent point. I actually like it.
Mhm.
But so that we all have the same background, the same kind of exposure to what the open meeting laws are, then it allows us to move forward in a more positive manner.
Do we need a motion?
Would you be
I'm fine with that. Do we need a motion to table or is it just a table?
I think I don't know. Glenn, do we have to, do you need a
This item number 10, correct?
yeah.
Which is an action item.
Can we,
I make a motion to
Tim, can we
table
just
this.
table it? He's nodding
Yeah,
his head.
just table it.
Okay.
Table it.
Yeah,
All
you
right.
can just table it.
Then I'm going to use my chairman's discretion and table the topic until next time. Okay, thank you. All right. Dr. Pinnock.
I guess I'm on. Thank you. The first thing I want to do is acknowledge Director Kettner and the staff. This is my 10th day on the job. And also thank the board for employment. I think that was an important thing for me, and I appreciate you doing that. Yeah, I've met already a lot of great people who all seem very highly motivated and passionate about what they do. Several of them in the room here today. So that's a good start. I was tasked by the board, as you know, to evaluate clinical services. And what I thought I would do today, I don't have any results, of course, after 10 days. But I thought I'd give you what my approach is and get some comments from the board and see if that's what you have in mind, and maybe offer other suggestions as you see fit. So this is more or less a strategy for evaluation. And Jessica, yeah, if you could bring up that PowerPoint. And you can go to the next slide. So as I'm as I'm sitting here.
Hold on 1 second because it's looking different on.
Oh. Okay. Well, so I started by saying, all right, what's health? And the Oxford English Dictionary gives a definition of health: the state of being free from illness or disease. And hopefully everybody can agree on that definition since it is Panhandle Health. Interestingly, there are other definitions out there. WHO has a different definition that says people can have disease, but they're healthy if they have a physical, mental, and social sense of well-being. I like this definition personally. Next slide. This is where I started with the mission statement, not foreign to everybody in this room, but to prevent disease, disability, premature death, promote healthy lifestyles, and protect health and quality of the environment. Next slide. So what are the big questions for clinical services? And I think that I distilled it down to this. What's the public demand? What are the needs or the wants of the people? And that may be one of the hardest questions to answer. From an epidemiological standpoint, what are the preventable diseases, disabilities, and preventable deaths in the Panhandle Health District? People are interested in knowing what we're doing currently in clinical services, so I will certainly answer that question. And then if there's to be restructuring, how can we better match that public demand with the clinical resources that were provided? Next slide. So I approached this scientifically, almost like a scientific paper or scientific project. And today I'll tell you the background and the methods. You guys are most interested in the results. We'll have discussion around those results, and I'll come to my conclusions. You all can come to your conclusions. I will give some recommendations, and then ultimately, of course, it's up to the board to accept those recommendations or amend them to determine what is best for clinical services. Next slide. So here's the background, at least as I see it. You could, there's an awful lot of things that could go into this background, but here's two things. How did we get here? So there's a changing landscape of disease in the United States, from an infectious or communicable disease type of landscape that we saw in the 19th century to chronic diseases that we now see in the 20th and 21st centuries. And just to illustrate that, here's some numbers from 2025, a couple of articles that I pulled. And these are staggering. This is one or more chronic diseases in those age groups. So 46% in children, 60% in young adults, 76% middle age, and the rest of us old farts. 93% of us have one or more chronic disease. I mean, that's staggering. Next slide. So based on the above definition of health, I would say that at least some aspects of public health are failing. We have to do better in one or more portions of public health. And based on the May PhD board workshop that everybody attended, there's the public distrust in Panhandle Health and healthcare services. So therefore, there's a need, if not a demand, to evaluate, which we're doing, modify, increase, or possibly eliminate some or all of the clinical services in Panhandle Health. And equally, or more importantly, we need to somehow figure out how to restore trust. Next slide. So how am I gonna go about trying to sort through this? Well, the first thing is to partner with Eric, with the executive director. Again, I've already bent his ear for about 4 hours worth, talking, asking questions. I probably had, 70, 100 questions that we went through over 4 hours, trying to get a 30,000 foot view of clinical services and And I've already started talking to many of the clinical staff and others involved. So epidemiologists, I talked to Kim already. But there's other related supervisors, staff that all kind of impact clinical services. It's a big moving machine. I've observed some of the clinical services already, but that's going to be a big part of this observation, observing the processes, the services, reviewing policies, procedures, and protocols. I want to get into the electronic health record and the practice management systems and put some numbers to the questions that the board had at the retreat and has had at previous meetings. Finances, dollars are going to be a part of that. We've already gone through some spreadsheets. And I'd really like to interview the stakeholders. I want to meet with each of the board members, hopefully in their own counties at the outlying PhD clinics. A, because I haven't seen those before, but B, the commissioners, the board members really are the ones that have the best handle on, I think, what the public needs. And so that's the part that's difficult. I've read the community health assessment. I will reread that. Community health, I think, has one every 3 years that it would be interesting to read. So trying to figure out what that public need is. Next slide. We will quantitate the ICD-10 and CPT data. ICD-10, for those of you who may not know, is the diagnostic codes that are placed on every billing sheet for patients that are seen in the clinic. The CPT data is the procedural or the evaluation and management codes that we can get from the clinic. And they'll be helpful in giving you a better picture of what's going on there. I'll try to quantitate as many things as I can, put numbers to it, and I'll try to present it graphically so that we don't bore you all out of your mind. But I'll try to make it look nice. Next slide. This is my disclaimer. Going into this, I had no preconceived idea of how the evaluation will turn out, what the recommendations will be. Of course, I have my own biases. We all have our own biases, but I tried to come in with an open mind. And I've asked the people that I've been meeting with to have an open mind too. Now, of course, I'm 30 hours into this, and I've developed some opinions now, and I will continue to develop opinions. But it was a blank slate when I started. Let me just say a little bit about compensation, because I know there's been some concerns about that. The hourly rate that was agreed upon with, for me, with Panhandle Health is a big number, $300 an hour. But what I can assure the board and assure everybody is that I'm not going to bill for every hour that I spend, not even close. So that $300 an hour becomes very cheap, very inexpensive, very quickly. In other words, let's say if I spend 40 hours a month and bill for 10.
Mr. Chairman, I apologize for interrupting, but legally we're obligated to pay every employee for every hour that they work. We would be operating illegally if we did not. So
Eric is speaking the truth, so we'll negotiate, we'll work on that a little later. So it's actually a federal employee law thing.
Well, I'm not obligated to. What's my obligation of spending hours?
time reporting is due.
All right, so you'll get the hours that I report. At any rate, my intention is not to be the line item that people talk about. This is not a money-making enterprise for me. If I wanted to make money, I'd be a cardiologist or I'd be a consultant. I could make a heck of a lot more money. I'm doing this because I think there's a need, because the board has asked me to do this. So I think it's important just to say that out loud, because I'm a taxpayer too. I want to save the counties as much money as I can. So I will be respectful of that hourly wage and try to minimize it to the extent that I can. Say that. Any questions or comments? I'd like to know if this seems like a reasonable way to proceed, if there's any other things that anybody can think of that I need to think about.
I'd love to make a comment. Dr. Pegg, I am thrilled that with your presentation and the direction you're going. This was the original dream, to find out what are the needs of the citizens of North Idaho. Is Panhandle Health meeting those needs? How can we better meet those needs? And you're going down that pathway, and I think that there's a tremendous potential that Panhandle Health will potentially immensely enhance the health of the citizens of North Idaho, especially when you bring up that issue of what are the major health problems, and many of those are being ignored by and large by obviously many people, or we wouldn't have such massive amounts of chronic disease, for example. That we must do a better job of addressing those issues and reducing those. And so I'm excited. This was the original thoughts when this whole topic came up, and you're going down that pathway, and I look forward to seeing what you come up with.
Just your thoughts on social determinants of health. I think in our case, you say, in my experience of dealing with families and clinicians and folks that are often that was a lot of.
I'm sorry, Peggy, I don't think your sound's picking up. Sorry.
No, I think it's a great question, and whereas I may be sort of programmed to think about disease states, that's not all there is. And when I looked at the community health assessment, one of the biggest things that comes to mind is access to care, a huge issue. So those things are all going to play in, and I can assure you that it's more than just disease X, Y, and Z. There are other issues in trying to, find the niche for Panhandle Health amongst the other players and institutions in the region is going to be the trick. But I hear what you're saying. I agree.
Any other comments?
Mr. Chairman, I just wanted to thank you. I appreciate the position you stated. And really like your attitude for the position.
I appreciate that, Glenn. Thank you. Yeah.
Any other comments? Okay, well, thank you, Dr. Pinnock. And we look forward to many future engagements with you. We are now item 12, the compensation package for Dr. Pinnock. Peggy?
This is really an item that is not an open meeting.
Do you want to go into executive session? We can. Okay, so we're going to use our cheat sheet. So what you need per 74-206, you can make a motion to go into executive session. That is itself a motion, and it has to pass with a 2/3 vote. And then if it passes, we go into executive session. So are you making such a motion?
I can't hear Peggy.
Peggy's requesting efficiency of the meeting with having to reset the teams, that we could maybe move that to our last item and then do it at the end so that we don't have the reboot time. I think it's more of just a practical procedural request.
Oh, I see what you're saying. Sure, I'm okay with that. Sure. So what we're going to do is
It'd be kind
temporarily
to everybody
table it
online,
and then come
so,
back to it and after Eric's director's report. Fair enough.
And I'll keep this fairly brief. I did not know that Pennock would be presenting, and so the intent of the first item that I have as far as medical director onboarding, I just wanted to follow up with the board and let the board know that per their direction at the last meeting, I did work with Sandy. We came up with a position description, as the board's aware, had communications with Dr. Pennock, and we did onboard him the last Tuesday. Brought him on as an employee. We do have an office and a workstation for him down in the clinic area, and put him in contact with program leads and program experts. And we've had a lot of discussions, provided a lot of information, giving him a lot to work with, certainly. So that's all I wanted to share with the board on that process. The other item is the Idaho Association of District Board of Health resolutions, the new resolutions that are going to be addressed at the meeting next week. To be honest with you, I don't know how much depth to go into on those particular items. There's 4 of them. They're in your board packets. I guess just to summarize, one is the Board of Health membership position statement. So that's coming from the Idaho Association of District Boards of Health, and their thought is that to continue with the statutory direction that elected officials can appoint non-elected officials to sit on boards of health. There was some interest last year that I think from one commissioner down south that wanted it to just be elected officials that sat on boards of health. So that statement is that things remain as they have been. The other one, yes.
Thank you so much. Director Kit. In discussing these, are these things that because I read through the whole packet, and it seems to be that they were produced by other stuff. And I went and read through the bylaws of the association to figure out where's that going on. So there are things that we can present as well. And so these have been presented by different of the districts for consideration. It's supposed to be produced a month before we go, I think, per the bylaws, so we can have a time to look at it. But the idea is that these are things that are intended to be voted upon. And so I think that basically would set desired policy, even if it's not a policy setting, because there's resolutions and then there's position statements. And so because of that, I've been doing my homework as a trustee. So because of that, we would probably want to understand them to some level to know if it's something we actually support or not, being that I'm going to vote in for representing the board, right? So, so just to let you know, I'm just trying to tell everybody, because this is the first time I even was really aware that this was happening, because I was pulling the bylaws up and learning and stuff, and then I saw these come through in the packet, and I'm like, oh, we need to talk about this. So just let you know, please continue, but I just wanted everyone to know that these are things that we may need to discuss if there's an issue with them or not, because next week they're being voted upon.
Yeah, and I appreciate that. And I guess maybe to provide a little bit of background, as I've experienced it with these Idaho Association of District Board of Health resolutions or position statements. The position statement is sort of the statement of that particular association. What they want to do with the resolutions is ideally some of them they want to push them to the Idaho Association of Counties, or otherwise possibly use those to alter current legislation.
Right. So they're pretty profound actually in the goal, even if in themselves they don't do anything as far as legislative or statutory, they may influence that to a significant degree, I think.
Yeah. And to share from a bit of a practical standpoint, what I've generally seen is IAC typically has a number of important items that they're considering. So it's fairly infrequent that these items are picked up.
Okay. Thank you. Thank you.
The second item is a resolution, and most of these came out of Central Health District report for reference. The second item is STI testing and treatment for minors. Apparently, there is some conflicting statute on legislative changes that were made 2 years ago that possibly testing and treatment of STIs, may be an acceptable practice without parental consent. And this resolution is simply seeking that the legislature clarify what their intent is.
Yes, and if I may, is that it seems to be more than clarification, but to reclaim the ability to do non-parental informed consent for 14 years and older. So they're trying to push the point of view from my read that they don't like that the current parents' rights. Exactly, I want to get it right here. Idaho, the July 1st, 2024, the Idaho Parental Rights Act became law. So they're trying to say, and the act is specifically written such that it supersedes. It states that it supersedes other laws that may contradict it. And so the other law that they're trying to reclaim rights for, again, is the law that states that clinics can do non-parental consent testing on 14 to, sub 18. So that to me, that's just to be clear. It's kind of like, be clear. That's what it seems to be doing, is it's trying to reclaim an old right that this law actually pretty clearly. I don't think there's actual confusion. It said this supersedes previous laws. They're just trying to go back and say, hey, well, you didn't directly say you repealed that law, so therefore, can we have it back, please? And so to me, whether or not you want that law back or not is not what I'm commenting on. It's more just what this is actually trying to do. So part of it would be a potential conversation is, as a board, what do we support? Do we support trying to supersede the or kind of try to get the legislation to roll back the Idaho Parental Rights Act, which is the newest act, and go back to a previous state in this one specific area? So that is my understanding. And if anyone else has another viewpoint, I'd love to hear it too.
Well, and to share that at that meeting next week, there will be further discussion on and clarification of that.
Yeah.
Central Health District
On their meeting and intent and all that. Okay. Are there drafts? Do the draft change if the discussion leads to that, or how does that work? Being that this is what's been submitted already.
To be honest with you, I haven't seen if they amend it in that meeting. I believe it's an action item in that upcoming meeting. Okay. But if it's amended, but as I understand it, several of these are simply items that Central Health District's board has reviewed and have asked to be pushed forward to the Idaho system.
Okay, thank you.
The third item is resolution supporting development of regional overdose facility reviews and enhanced data reporting in Idaho. What this appears to be looking to do is to require that coroner data be provided to health and welfare, so that local committees, health districts, frankly, can utilize that data in understanding where overdoses are occurring and what drugs are the cause of those overdoses. The current data that's available is through EMS. It's largely voluntary, and it's somewhat anecdotal because it's what, assuming the individual, well, I guess if the individual survive, that they basically self-identify what substances they took. Certainly, if an individual passes and toxicology report exists, then you have pretty specific information on what substances are.
Okay. Do you know, is there a mechanism currently for overdose survivors to go and get blood drawn not at their expense so they can identify? Because right now a lot of overdoses are actually unknown because they're laced where the person doesn't even know what hit them. And so if there isn't, that may be something we want to do if we're really trying to pad out this database with useful information, is to say, if there's an overdose, you get a no-fault blood draw, and we're going to do a toxicology on it to figure out what actually, and you survive. Because imagine the coroner might do that. I don't know if they do, but in each county.
But maybe to get clarification.
Yeah.
Do you know that?
There are programs for Idaho corners to use this community toxicology for free. DHW will provide them
We'll provide them with the supplies they need so they can test, but those are just for county coroners. I'm not aware of
Mhm.
any non-fatal overdose options for
Mhm.
people to go get tested for free.
Right. Okay. I think based off of even what some of the sheriffs and the commissioners are trying to do that kind of supports what this is all about,
Mhm.
we may want to look at trying to figure out how to do that so we can actually get information on the survivors.
It'd be wonderful data to have.
Because then we actually know where we can identify clusters that are happening, and issues of contamination and stuff like that. So anyway.
And the final item, again, from Central Health District is about swimming pool inspection program. That's been a longstanding program where health and welfare had contracted that to the health districts. It's a fairly small program, to be honest with you, because the definition of a public pool is fairly narrow. That rule set was part of health and welfare's legislative package last year, and those rules no longer exist. And there is interest by Central Health District to have those rules reinstated and the health district have the ability to implement them.
Do you know, and anyone in DEQ, environmental quality side, do you know, since that's changed, has there been any measurable upticks in illnesses that are, polio through pools I think has been long gone, because chlorine basically kills that as one of the main reasons for chlorine pools. But has there been a negative change in that? And what would be the desire? What benefit would the Panhandle Health District have in supporting this? If you wouldn't mind commenting on that.
Yeah, there was a look back on outbreaks associated with pools and splash pads over the past 20 years. I guess to answer your question more directly, since the rule changed, I'm guessing the data is very limited. Probably not a significant instance. There have been outbreaks, fairly significant outbreaks at different times. To be honest with you, it hasn't been tremendously compelling based on our review of the data. Jason, I don't know if you want to provide some.
Yeah, I think the main answer to your question would be that I don't know that we've had enough time since the rule set went away. It's basically been 3 months. And then back to the other part of your question, which would be what would the benefit be for Panhandle Health District? One of the main roles that we previously, when there was swimming pool regulations in Idaho, and then still continue to play in that regard, is education and support of the facilities. And so especially in the outlying communities, and we're continuing to do that, on a voluntary basis. And so that's, from our purposes, one of the main points of that. It's not just about the regulation, but the education, the resources that we provide, particularly in areas where they don't have access to good resources, training, for example, things like certified pool operating courses. So we're continuing to do that on a voluntary basis. And essentially all of the pools that we previously regulated have expressed interest in continuing that. So we're still going to continue to support our communities in that way.
Yeah.
But yeah, I just don't know that we have solid statistics in comparison, since the rule set went away, because that was in July. As it says in the overview here, many of the outbreaks that have occurred or illnesses have been at unregulated facilities, gyms, hotels, other smaller aquatic facilities that haven't been regulated since about 2000. So that may be another interesting comparison, since there is more than 25-year span, because there was a big increase in regulation about the year 2000, and that's one thing that is pretty apparent from the statistics that we do have.
And would you say some of the issues or outbreaks or injuries, is that some of that like just trauma injury, or is it more related to the quality and management of the water services, the water?
There's been a number of
waterborne illness outbreaks, Campylobacter,
Okay.
for example. There's Legionnaires. Trying to think of some of the others. So I could get you some more information on
Yeah,
that.
sure.
I've done the research on it. I don't have it all in front of me.
Yeah, thank you.
But yeah, it's kind of a combination of both. And there can be
Mhm.
some physical safety concerns,
Mhm.
turbidity of the water and so forth. And so again, that's really,
Yeah.
Any of the regulatory programs that we operate, fundamentally we're regulators, but to be effective, we're primarily educators.
Mhm.
And that's our role within this nuclear program, just like it would be
Thank
in
you.
safety septic program.
One more quick question on that. Is there, if we're doing voluntary support to
Mhm.
support the community, where does the funding for that come from? Or is that just kind of trying to work it into the daily work schedule? Or, and would they pay, or would there be funding if it was back into mandatory?
Well, that's a great question. So even prior to loss of the rules, we did not have any funding from the state or counties. It's a fee-based program with fees set in statute that essentially don't cover the cost of the program. So what we are doing is part of your question, which is to kind of include these pool inspections, consultations within our normal part of our work schedule. The environmental health specialist that inspects the pools also does the child care health and safety coordinator. So she's all through all 5 counties, and she just kind of includes that in there. Separate from that, we've offered to, if there's any consultations separate, that we could charge base consultation rate. And there's several facilities that have expressed interest in that. So kind of what our model is going to be, just to really try to support the outlying communities, the small communities like Kellogg Pool, for example, St. Mary's School would be to kind of keep that same fee schedule in place so that it's not a financial burden to those cities and counties, but reducing our internal costs by including that as part of the days. So that answers the question.
And just to add one final comment, to give you scope, under the current definition or the past most recent definition, it was 14, 15 pools total in the 5 northern counties, and a number of them were county-operated pools or city-operated pools. Considering we already get funding from the counties, it made sense for us to continue to offer that education assistance. There are some commercial facilities as well, but it's a fairly small scope.
Thank you.
Yeah, and one other point I'd make is just the fact that there is pretty much uniform interest in continuing to have this on a voluntary basis really kind of demonstrates the role that we serve for this park. So it'd be a good reason to get rid of us. But many of these smaller cities and counties just do not have the resources, the staffing, to protect the communities of children that use these facilities. So that's really why we're committed to maintaining that.
Okay.
Well, let me just add a little addendum to what Eric was talking about regarding next week's meeting, and that is it's possible that you can actually send a proxy. The Idaho Association of District Boards of Health give all board members the opportunity to give your proxy to Joel. Now, you don't have to, and if you do give your proxy, you can certainly read what the propositions are and let him hear from you as to how you would want him to represent your thinking, which he would probably be appreciative of.
I would like that. Yeah.
Now, Joe,
I
the
understand.
3 of us are going, or you can tell me what your thinking is also.
Well,
but
Chairman, I think that the proxy, as far as I understand it, I could be wrong. It's more if someone needed to go in lieu of me if I couldn't make the meeting, then we would generate a proxy for that. It's not, so the proxies in case I couldn't go. But I would love to hear from everyone as far as your pro
all I'm
or
doing
con.
is quoting this piece of paper.
Okay.
Is it legal? Hell if I know, but it's from them.
No, it's not about it legal or not. It's
I don't know.
okay.
You don't even have to, if you don't believe in sending the proxy, don't send it. I'm just giving you that option, board members. If you, I can tell you, having attended a couple of these, that other districts who are hundreds of miles away do give to their trustee a proxy, because I'll hear them stand up and say, on behalf of the 7 people from, District 3, I want to make the following comment. They do say that.
That's great. So this by a proxy or more means like if you want something that somebody wants me to communicate, not per se vote, but
Vote.
Both. I
This piece of paper
gladly do that.
just authorizes you to speak on behalf of Peggy.
Okay.
Or a virtual Peggy. Whether Peggy actually wants it wants to influence your thinking on swimming pools, well, then that's a conversation the two of you have. And she, I mean, Glenn will tell you, I mean, he did this for a decade.
I got 3 in favor and 4 against.
There you go.
And they're all tabulated. Final vote.
Thank you, Glenn. So then a good thing would be is if the board members could, was it best
Well,
for
I'm
to
gonna
me or
ask
send to
Jessica.
Jessica?
Here's what I'm going to do.
Yeah, send to
Jessica
Jessica.
is going to send this as a email to everybody. If
Mhm.
you want to exercise your option, do so. If not, well,
Also, maybe anybody interested could send Jessica, and please, even if you're not interested, whether you'd like yes or no on these different ones, and then she could tabulate that. Is that right if I volunteer you for that? And then send that to me, so I'm not communicating with everybody. And then take that and then represent everyone through that. Does that sound good? Okay.
correct. All right. You're done? Mighty fine. Okay. As promised, Peggy, we're going to come back to you. The floor is yours.
Get my notes out in front of me. Thank you, Dr. Nolan, for having that in the packet.
My pleasure.
Yeah, we're going to, well, I don't know. It's a motion
Well,
to
I'm
go
gonna
into executive session,
Make a motion
and then it has to pass.
to go into executive session per Idaho Code,
1B.
Idaho Code 74-206 J.
1J.
No, I guess that's.
I don't know. Joel had this huge cheat sheet. I mean,
Or
ta-
it would be 74-206 1B.
1B, exactly.
Oh, okay. All right, there we go.
Okay, so you're making a motion.
I made that motion.
Is there a second?
Mr. Chairman, I second it.
Okay, roll call vote.
Glenn Bailey,
Yes.
Dr. Johnson, Commissioner Cowles,
Yes.
Commissioner Bertling,
Yes.
Dr. Nolan, Peggy Cavallo,
Yes.
Chairman Fletcher.
Yes. All right, we're going into executive session. The motion is to go back into
Okay.
order.
And that was a motion that you made,
Well,
or
I
was
guess I
that?
can't. Will someone else make the motion to?
Mr. Chairman, I make a
Okay.
motion to go come back to regular session.
All right, we have a motion.
And
Second that.
Second, roll call vote.
Glenn Bailey,
Yes.
Commissioner Cowles,
Yes.
Commissioner Bertling,
Yes.
Dr. Nolan,
Yes.
Peggy Kavala, Chairman Fletcher.
Yes. All right, now we're in regular session. Fair enough. And actually, I'm glad Sandy's here. Now, can we, I'm so confused as to this stuff. What we talked about was actually moving forward, and you're going to be front and center with this. In fact, you're going to do it. The concern is that we want to be legal with Dr. Pinnock's salary. So can you make that happen? Knowing that he's going to work for $18,000 for 6 months. So doctor that up in such a fashion that it's legal and it meets the budget, and he doesn't have to commit fraud by submitting incorrect hours. I mean, he realizes that if he were paid $300 an hour and he's putting his heart and soul into this, it doesn't fit the budget.
While you guys were in executive session, we were actually solving the problem.
Oh, you solved the problem. Well, there you go. Thank you. All right, Sandy. Well, hallelujah. Thank you. So you're going to make us legal, and life goes on.
We can change the pay rate so that the hours he works can meld together and balance to meet the budget.
Right. That's it.
The other option we have is that we could do just a set hours a week. So it would almost be like an exempt position. So it's 10 hours a week. He gets paid for 10 hours a week, whether he works 10 or 20 as an exempt employee would. We could have that option as well.
Oh,
That one's a little more dicey for me simply because the state's payroll system requires you to be exempt to be 40 hours a week. But I can enter that as a set schedule for him just manually by not making him an exempt employee, but treating him like one.
my strong recommendation is that we make you and Dr. Pinnock happy. Okay. And I want to go on the record, minutes, that I want to thank Peggy for forcing us to actually work through this detail. It needed to be worked through before we find ourselves months down the road having done wrong things.
Yeah, thank you, Peggy.
So there you go, Peggy. All right, do I hear a motion? Let's have a very important motion.
I make a motion to adjourn.
Yes, do I hear a second? Do I hear any objections? Hearing none, the meeting is over. Thank you, commissioners. Thank you very much.
Thank you.
Thank you. Bye now.
I'll just get together with Dr. Pennock and Sandy and we'll hash it out. Yep, that's easy enough.
And it did need to be made. Actually, it was interesting. You knew that